So first I want to thank everybody who showed up today. I do have a great presentation for you. I do think that the issue of gender diversity is an important topic today, especially. So I really appreciate them stepping up to the game and having presenters like me here to present. So before I start, I'm just curious to see how many people in the room already work with gender diverse people. Okay. And for the rest of you, if you can raise your hand if you're interested in working with gender diverse people. Okay, and so I'm assuming then that everybody else showed up for continuing education credit, right? Okay, which is totally fine. I'm glad you're here. It's still going to be an interesting presentation for you. So today's presentation is going to be on diagnosis and treatment of gender diversity. One size does not fit all, and I'm really going to stress out one size does not fit all throughout the presentation. I'm a little bit nervous in the beginning, so bear with me. So just to briefly outline where this idea of gender kind of stems from. And the idea of gender today stems from, one, biological sex. So we're really looking at biology. That gender is an attribution of biological sex, and we have male, female, and intersective. We're looking at biology. And the second idea of gender stems from social constructed view, and that's the view that society and culture create gender roles, and these roles are prescribed as ideal and appropriate behaviors. So basically the idea is that yes, we do have biologically variations of gender, but then we also have the social constructed ideas of what really constitutes male and female, and we layers them on individuals as we go along. So within this idea of gender, we have today in society at least kind of two predominant views. We have binary view of gender, and that's represent idea that there's only two genders, right? So the idea that there's only male or female, very strict, rigid binary ideas. And then we also have, or this view currently predominates in our culture, as you know. This idea is strongly rooted in biological sex attribution. So that's one of the views. The second view that predominates today as well is gender is the spectrum, right? So we have male and female as one of the extremes. And then in the middle, we have all this kind of different variations and expressions of gender identities today. So this is, what we're being on the cusp of kind of gender revolution. I like to say on the cusp because we're not there yet. But this is ideas that tends to take over, at least in, kind of like really big liberal cities like Los Angeles, New York City, and whatnot. So today, just to simplify it, I'm bringing it down to a very narrow. I know this is very reductionistic because gender is incredibly diverse, but I'm simplifying it for the sake of discussion. So really three kind of gender identities. We have cisgender identity, transgender, and gender non-binary. And this is only for the sake of today's discussion because we have a limited amount of time. I do want to rush through the introductory portion because I want you guys to get the most out of kind of clinical diagnostic portion. I think that's the most important part of the discussion today. So cisgender, for those who may be not familiar with the terminology, is basically a person whose gender identity and biological sex are the same. So I would be a cisgender female. So my biological sex assigned at birth is female. I strongly identify also with female gender. So this would be a cisgender individual. So for those of you in a group who strongly identified with your biological sex assigned at birth, you would be considered cis/male, so this is considered female. Transgender, on the other hand, are people who don't really feel comfortable with their biological sex assigned at birth. So usually people who desire to be opposite of the gender or to fall somewhere in between, in the middle of the gender spectrum. And within transgender identities, we really have a variety of variations, and I only kind of scratched the surface today because constantly the language of gender diversity is changing. So to keep up with it, as you all know, is very difficult. And also what's happening is the transgender umbrella is taking up much more gender diverse individuals underneath it. So I'm listing again a very reductionistic view today. So we have male to female, known as trans women or transgender woman. We have female to male, known as trans man or transgender man. Then we have transsexual, which is really a clinical term that's still very predominantly used in Europe. It used to be a clinical term that denotes anybody who strongly identifies with the opposite spectrum of binary and actually goes to the extreme surgical transition in order to achieve the binary. And that's a term that I think still clinically appropriate to use for that population. And I'll get later in discussion about partial transition because not everybody goes through full transition. But today, a lot of trans people that I work with really like to use the word transsexual to kind of explain their sense of identity because they really don't fit anywhere on the middle of a spectrum. Their goal is really to shift to another binary and to be passable in the opposite gender. And then, as I mentioned, there's also a whole area of variations that fall underneath transgender umbrella. Gender non-binary is another form of gender identity that people use today, and that describes gender identities other than commonly socially constructed binaries of male and female. And this is a good picture that summarizes some representation of gender non-binary expressions. Now, I know that a lot of people will not agree with this picture. Again, everybody looks at gender very differently and through a different lens. So there is no common agreement what constitutes transgender, gender non-binary, gender non-conforming. It's really kind of subjective understanding of yourself and of your experience. But I do think overall this does a really good job of listing some of the gender expressions and identities that fall into non-binary spectrum of gender identity. As we know, not only gender is a spectrum. Our understanding is also that sex is a spectrum, gender expression is a spectrum, right? We have expressions from strictly masculine to strictly feminine, and then people fall somewhere in the middle. And sexual orientation, as many of you here who work in the sex field also know that it's a spectrum as well. So we're kind of shifting slowly toward a lesser biological streamlined understanding, not only of genders, but also of our sense of who we are, and more toward the spectrum with a lot of diversity kind of clustered in the middle. So let's shift to the clinical portion. And I'm going to really slow down here. And I encourage everybody in the room, if you have any questions, just raise your arm. Don't wait until the end of the discussion. So this way we can kind of answer the questions as you go along and you don't forget what they are. Many of you are probably familiar with DSM. I'm assuming everybody in the room uses DSM at one point or another. This is diagnostic criteria currently in DSM to diagnose for gender dysphoria. And I want you to notice a few things. So I bolded word incongruency, desire, and desire all over again. So let's look through this. So in order to diagnose somebody today, to have a gender dysphoria diagnosis, they need to have at least 6 months of distress, and it has to be shown by at least 2 of any of these characteristics. So we have marked incongruency between one's experienced and expressed gender and primary or secondary sex characteristics, a strong desire to be rid of one's primary and or secondary sex characteristics, a strong desire for the primary and or secondary sex characteristics of the other gender, and a strong desire to be the other gender, strong desire to be treated as the other gender, and a strong conviction that one has the typical feelings and reactions of the other gender. Anybody has any idea why I bolded desire? Any?
Because you can have the desire and not have, taken any legal, social, or other steps, and still have dysphoria.
Yes. So that's one. That's great. Thank you. Another reason is because I want you to notice we're talking about subjective experience. We're talking about subjective sense of who you are. So what's your strong desire is going to be subjectively drastically different from my sense of strong desire. So from get-go, we're talking about something we cannot clinically measure. There's no statistical test, really. There's no standardized test that I can give you that will kind of measure for gender dysphoria. I can give you tests that will tell me if you're experiencing distress, how severe your distress is, but it won't tell me what your gender identity is. There's no tool on the planet that does that. And that's why I really outlined that. So when we're talking about psychological testing, again, there's no test at all that can measure for that. I know there's quizzes when you Google online and you put in, what's my gender identity, you'll pull up some very reductionistic quizzes that really kind of, I don't know if any of you looked at them, but they're tailored to see if you belong in other binaries. They're kind of tailored more to, in a reductionistic way, to measure if you fall into transsexual category, how strongly you feel really incongruent with your biological sex. But there is no other test that I can give. So somebody walks into my room and I need to diagnose them, because right now what I do, and I've been doing for 3 years, is I provide all the evaluation for any kind of gender transsurgical services, the letters that people need in order to file this insurance. I do them all for free to support community. So I do about 5 or 7 a week. So when people walk into my office, I have to diagnose, and I usually do them within 1 session. I have to diagnose them properly. I have to make sure they have gender dysphoria. I have to make sure they're able to consent and understand and have capacity to consent to medical treatment. And I have to also assess for a whole bunch of WPATH guidelines, right? So they walk in, and I'm pulling out the SM criteria that we seen earlier. How am I supposed to do that? What am I measuring that strong desire against? And that's one of the biggest problems, is that it's subjective sense of reality, is that there's no really tool I can have that objectively measures the level of distress. The problem is, and I hear this all of the time, with clinicians who give them MMPI. Are you all familiar with MMPI? Okay, or WAIS? I had somebody walk into my office and say that they called a clinician to get a letter for a surgical procedure. And the clinician said, well, I'm going to have to see you 6 months to a year, which is ridiculous. I don't know what they're doing within 6 months in a year. And I'm going to have to give you WAIS among other tests. What are you doing when you give somebody WAIS? What are you measuring? Anybody knows what a WAIS is meant to measure? Right. Why are we measuring intelligence? Why are we first not only pathologizing, but demeaning gender diverse people by giving this psychological test? When I did my dissertation, my literature review was incredibly small, and all of it was tailored on one thing: pathologizing gender diverse community. All of it was giving them MMPI, especially, to measure if there's something going on, so that we can explain this is why people have gender identity dysphoria. Okay? So in other words, what pathologically going on with a person that they really don't feel comfortable with their gender. And this is majority of literature review, and this is the problem why clinicians to this day use testing. And this is a huge problem. This is a big pet peeve of mine. And I understand everybody has to start somewhere, but we need to start with realizing that we're talking about subjective sense of experience that truly cannot be measured. It's almost like me coming to your office and saying, I like bananas. You're saying, well, how, to what extent you like bananas? And I say, I really love bananas. And you say, well, okay, you have a strong desire. How can I measure that? What are you going to give me? There's no test. There's nothing you can do. And that's the problem. So as mentioned again, we're measuring subjective sense of experience. And so the only test, really, that we can give people is listening to their subjective narrative. And that's what our discussion is today, because I have noticed over the years of my practice that a lot of clinicians struggle to understand what are we trying to listen for and how we need to measure that subjective sense of experience so we can properly diagnose this population. Okay? And the problem stems with the way we've been historically taught to diagnose. This is actually kind of psychology 101, something that I do regardless what kind of psychopathology I screened for. Although I solely focus on gender diverse community. I don't work with any other population, so for me it's a little bit more streamlined. But historically, hopefully all of us have been taught to look for symptomatic representation across lifespan and across domains. And if you haven't done it, this is a great way to kind of assess any kind of presence of diagnosis. What do I mean across lifespan? So in our example with gender incongruency, right, historically we've been taught, patient comes into the office and they say, I feel very uncomfortable with my gender. Then we're asking them, we have all this kind of historical developmental interview, right, that we do. And we ask them, okay, when was the first you experienced gender incongruency and discomfort? That's assessing across lifespan. And hopefully we're looking for pattern, and hopefully we're looking for consistency. So childhood, I first felt it, around age 4 or 5. 4 is actually a good age when children are become developmentally self-aware of what their gender is. So 4, okay, what about preteen? Did you still felt incongruency? Yes, okay, great, pattern continues. What about once you hit puberty? Yes, what about, and then depending where they're at their age when they walk in, right? So we're looking again for this consistency and across domain. Is there incongruency and discomfort that manifests in a family environment? What about at school? What about at work? So this is what historically we've been taught to do, and here's the big mistake. We've been taught to listen historically for 2 things, and people still do this. This is what I was taught to do 10 years ago when I started. 1, when we look at the lifespan, I'm supposed to look for discomfort with gender starting at age 4 and up to about age 7, okay? So historically, I was taught to look for very particular age category. And then I was supposed to look for a narrative that goes something like this: I am trapped in the wrong body. Okay? So this narrative historically denotes a very severe dysphoria. So if a patient comes in and they say, yeah, I felt really incongruent ever since I was a little child, and I really feel trapped in my body, I don't feel comfortable with my body, boom, you have gender dysphoria, here's your clinical diagnosis. Okay? And there's a big problem with that, and clinicians to this day look for that. The problem, and I'll show you later, is that because we're seeing a shift, we're seeing many more people coming in, and they're coming out much later in their life. And when I say much later, I mean much later. I have a patient who's 86 years old, who just became aware of their gender incongruency. There's no history to back it up. And I will explain why. Why is there no history? What happened? Is it possible that the person really had no history for such long period of time? And if so, how do I properly assess, right? What am I supposed to look for? Usually this narrative also denoted a true transsexual. Again, this is an individual who strongly did not identify with their biological sex and really wanted to kind of go to the other binary. This narrative is less common today. So here's the problems with this classic narrative of I'm stuck in the wrong body. One, it skews, statistically it skews our kind of representation of the community. And how did it happen to be skewed is this. Historically and to this day, we're known to be gatekeepers. We're known to be people who stand in a way of gender diverse people getting access to any kind of medical treatment. And because we're not being taught properly how to assess and diagnose, we take longer time. We're waiting for people to say age 4, age 5, and stuck in the wrong body. And I kid you not, it does not take long for trans community to catch up to that narrative and then to come to the office. And to this day, I have people bring in that narrative. And when I probe, and when they understand that they're sitting with somebody they feel comfortable with, and I trust them, and they don't have to prove to me their identity, they drop the narrative. Okay? So this happens to this day. Out of 5 to 7 evaluations I do a week, probably about 5 of individuals come in, and before I even ask them a question, they give me an elevator speech, you know, all of the elevator speeches of their gender identity, and they sit there and they have the need to prove to me why they need that letter and why they identify the way they do. And their sense of identity is usually very, very severe. But do they really feel that? Sometimes not. And that's the problem, is that they're kind of trained to give us this elevator speech. So as a result, we also continue to perpetuate that this is what we diagnostically need to look for. It also continues to generalize experience, and that's one of the biggest problems. It no longer defines experience of younger generation, and I'll explain why, but to briefly say, today what's happening in our culture, we're kind of saturated with gender diverse language. So younger generation are experiencing dysphoria to a milder degree, a lot of times, because they're able to kind of talk about their identity, express their identity. They have other tools at their disposal. And so that a classic narrative, I'm stuck in a body, doesn't really apply to them at all. That's not their vocabulary. And then it can also perpetuate gender identity as a binary concept, because when you say I'm stuck in the wrong body, you in many ways basically saying that the bodies that I have is not the body that I belong to, and it's only the binary that is acceptable. Does that make sense in terms of a narrative and the problem with the classic narrative? Okay. So why are we seeing the shift in narrative? Why are we seeing more and more people coming in and coming out and becoming aware of their gender identity much later in life, right? And why are we seeing a different description of narrative? Today, many of the things that we see, is, at least I see in my practice, is that people are starting to describe their dysphoria ranging from mild, often seen as very mild discomfort. I actually did I just started YouTube videos, and I did video on this because so many people wrote to me and said, what about, people who have zero dysphoria, but they're transgender? And what they're actually saying is not that I have zero dysphoria, but I don't have dysphoria as severe. I have discomfort, but I no longer associate discomfort with the word dysphoria. But technically what they're saying is I have discomfort, AKA I have dysphoria, it's just not so severe, it's mild. I don't want to, for example, a good example is, somebody feels dislikes their biological sex and how they're perceived, but they don't really feel trapped in their body. Many more people coming in for partial transition, and I'll talk about that a little bit more later in treatment options, but we're having more and more people coming in saying that I feel very uncomfortable with my breasts and I want to get rid of my breasts, feel very comfortable with my genitalia. Happens all the time, and it's very confusing to clinicians, and I get people call me to consult about this case because they're sitting there evaluating them for gender services, and they're wondering how can it possibly be that they want to get the surgery, but they don't want to get this bottom surgery, aren't our genitals the big precursors of our identity? And that's the problem. They're seeing through that one binary lens that we've been trained to see. And we not only kind of perpetuate that, but we also prolong the distress of these people because we assess longer, because we're not competent enough, we take longer to diagnose, we take longer to get them their letters that they need, and as a result, they suffer longer. And it's not fair, and it's not fair to the community. So we're really seeing the shift. We're also seeing the shift not only in narrative, but also in the age presentation. Again, historically, we've been taught to look for, around age 4, but today we need to realize that, people coming out later and later in life. This is something I put together, extremely reductionistic. Don't quote my statistics. This is my observation working, with trans people over a long period of time. So the blue line represents historically what we've been taught to look for and pinpoint. We've been taught to look for people coming in and having a lifespan of incongruency or discomfort, starting at age 4, going up to around age 7 or 5. If they have it, we put a check mark in our kind of history intake. Great. Combined with discomfort and dysphoria and your perfect classic narrative, your gender diverse person, here's your diagnosis. Now, this is what I'm seeing now. And the line actually goes way higher. I'm still seeing some people come in and they're having discomfort at very young age. Then I'm seeing people who have a gap. They haven't felt discomfort. So at around age 4, when they had a sense of who they are, they were comfortable with their gender. And then when the puberty hit, around the puberty age, and people started to develop secondary sex characteristics, that's when it's kind of spiked up in the realizations. They started to realize that they don't feel comfortable with their biological gender. Then we have much older in life, and we see all the way up. Like I said, I have a patient who's 86 years old, and right now kind of trying to figure out what part of transition is really fits for them, because there's medical conditions, concerns, and whatnot, and later in life, and they're trying to see what their options are. So it's not that uncommon. So the question is, why are we seeing people who coming out so late in life, and why is it that they don't have any kind of history at all about their incongruency dating back to childhood or just dating back to any part of their development? And one of the answers is psychic repression. As many of you know, psychic repression is part of defensive function, and I observed that being very incredibly common with trans people. Okay? Statistically, I see it being observed the most with people who tend to come from very strong religious backgrounds. They come from lives that have strict binary gender roles. Mom kind of had this, strong social constructed idea, stay-home mom, nurturing, always food on the table, and that was like really masculine, strong authoritative father. And they come from geographically small, conservative rural areas. So let's think about this. If you were to grow up, so first of all, the people who are coming out later, right? We're talking about later, older generations. If you were to grow up in this environment, and let's say age 4 or 5, you're feeling some kind of gender incongruency, right? Well, back then, first of all, you don't have vocabulary for it, right? You don't have the context to explain or mentalize your experience to anybody. You don't really understand the scope of your experience, and if you do go to your mom, and somebody else's. It's kind of a milder ringtone this time, no music. So if you go to your parent and you express any discomfort to your parent, and if you come from this background, what's going to happen? Chances are your parents are going to say, what are you talking about? You're not supposed to feel this. So in a nutshell, I'm describing a very transphobic environment, right? I'm describing an environment that is strongly rooted in binary points of view. Shaming. Lots of shaming, lots of guilt, right? And so what happens to us when we feel shamed? How do we cope with that? And when we have no outlet, we have nowhere to go, we're living in a context where there is no vocabulary to mentalize our experience, so we can't really go and talk to our peers, right? We can't maybe couldn't get on YouTube and look up gender diversity, or you couldn't get up on Google and look it up and have an understanding. So as a result, you stuff it away. And as we know, clinically, stuffing it away is, on one hand, is a really good defense for trauma. When people going through severe trauma, it can really help people not to have psychotic kind of break. But the problem with stuffing it away is that it becomes repressed material that eventually comes up, bubbles up. So why are we seeing now in an older population this kind of awareness and realization of incongruency of their gender? Well, for one, they're being saturated in our environment. They're being fed. They put out a news and they see, on the news something about trans experience, or, there's a lot of TV shows now. So the language is all around them. So that language tickles the lid under repression. So eventually that lid goes up. And when the lid goes up, this is the people we see. This is at least a lot of people that I see that are older coming in, and they're completely confused. They're freaked out. They have no kind of, it's a little bit better when somebody does actually has consistent developmental history, because at least they psychically try to make sense of it throughout the years, versus when material has been repressed for so long, and you lived in a wrong gender identity for so long, and now you hold not only your identity, but the scope of your life. You may be married, you have kids, maybe your work now revolves around your sense of who you are. So it's so deeply, it's almost like looking at a tree that has a very deep root, but it doesn't belong where it was rooted. What do? Do you just uproot it? Well, you don't really also do that. So it becomes really difficult for people to get it. And when I get couples come in, it's interesting. One partner would feel this incongruency, and usually another partner will look at me, and this is usually, it tend to be women, wives, and they would say, well, could it be that he's going through a middle-age crisis? And I'm sitting thinking there, well, this is one hell of a way to go through a middle-age crisis. Wouldn't it be easier for him to buy a car? So it's really hard for people to understand. I had a couple come in who, the man was in his late 50s. They've been living together, comes from, again, from that background that I pointed out, very highly religious, small area. And they came in because, now this person having this realization that, oh my God, maybe I'm trans, maybe not, I'm not really sure. So they came in for maybe 2-3 sessions, and then they said, he called me and he said, you know what, I did this cleaning. I had somebody come in and clean this aura of negativity. I just want to let you know so you can share this with your future patient. It worked, I'm totally fine. And I said, that's great. If that worked, I'm really happy. I'm happy you're able to go back to your life. Deep down inside, I know that doesn't really work, but what I'm trying to say is, it's a great example to what extent we as humans go to cope and deal with realization of something so drastic at such later age. And that's really sad and really scary, terrifying, that this person had to go through another kind of mental conviction that this is just a negative hour, this is not happening to me, and I don't know how long it's going to last for them, but it saddens me that this is what's happening. And it's happening because we're having a shift in the narrative. We're also seeing the shift in language. Again, as I said, current culture possesses vocabulary to describe gender diverse experiences, so it's all over us. The language to define gender diversity is also part of our daily lexicon. And that also shifts our social construct. The idea that gender is a construct and that it's not just binary, but it's kind of diverse and everywhere in between is being also shifted by the media, right? Because we're seeing more gender diversion and more gender kind of inclusion in the news. We have post-transparent, we have celebrities, have real shows. So as kind of language shifts, the social constructs and understanding of gender shifts. And that's a really great thing because it enables us to kind of better understand how to properly diagnose this population. So all of the shifts are happening, right? And we're having people coming in and they're coming out later in life, and they don't have that over across lifespan and across domains type of consistency, right? And we're sitting there and we have to diagnose them, and we need to diagnose them properly. And one of the things that we need to do is we need to recognize and be aware of the shifts that's happening, and to stray away from the classic narrative of I'm trapped in the wrong body, and to strip away from looking for the lifespan manifestation of 4 years old. So can we still listen to the narrative, and can we actually still diagnose across lifespan and domains if there's gaps missing? Absolutely. Why? Because we're still looking for consistency. We're still looking for distress that manifests in different domains of their life. So yes, we absolutely can. What we cannot do any longer is we can no longer really pinpoint it to a particular age group. We need to be open-minded enough to know that things are happening differently. So how do we properly diagnose? Again, there's no testing. So we're really listening to gender incongruency across lifespan and domains, and we remind ourselves that we're listening to a subjective sense of identity. It's their truth, it's their reality, it's how they see themselves. And I'll talk a little bit later in dual diagnosis, because we also have to be properly looking for this. there is a lot of people that I see that do have dissociative identity disorder, that do have sometimes psychotic manifestations. So we also need to be properly seeing, is there anything else going on that can explain their sense of reality, their sense of identity. So we're also doing reality testing. As we properly diagnose, we're seeing for, is there any repressed material? And if there is, why is that material repressed? Not only does it give us a better sense of how to properly derive at the diagnosis, but it also gives us a better sense to understand and not to further pathologize why somebody doesn't have the classic narrative. We're looking for presence of dysphoria no matter how mild. Again, we're not looking for a strong desire, whatever that means for you, sitting there maybe as a clinician who's very comfortable with your own gender, right? And you're thinking, well, for me, a strong desire would be really going to another binary. We need to understand that for a lot of people, a strong desire may just mean something very mild. It may just mean that, you know, I identify as non-binary and all I want to do is just kind of dress in, borrow from a little bit from both binaries, and that's all I pretty much want to do. I don't want to go through transition. And we also note that various gender identities fall under diagnosis of gender dysphoria apart from transgender. One of the biggest mistakes clinicians tend to make is they equate gender dysphoria with transgender identity, male to female, female to male. No, there's nowhere in DSM-5 does it say that gender dysphoria, if you have diagnosis of gender dysphoria, it equals you being transgender. Nowhere does it say that. And WPATH guidelines are not just reading for transgender people. They're reading for transsexual, transgender, gender diverse, gender non-binary. So it's really important that we're basically looking for really level of discomfort and competency and capacity to be able to consent for any kind of treatment if the person wishes to do so. And I'll touch base diagnosis a little bit later. When we start working with this population, so let's say, you know, now you have a better understanding of shifts in the narrative and how to listen to it, and now you're starting to plan for the treatment. Well, treatment really begins with validation of narrative. I can't stress how important it is. When somebody, again, tells me they've been quoted to be seen 6 months up to a year in order to get gender dysphoria diagnosis, it baffles me. You're going to have a person sit every single week, and sometimes ask twice a week, 6 months to a year for them to tell you what? Explain what? So it's really baffles me, and it's very painful, it's hurtful, and it's completely unnecessary. To me, that's usually indication of incompetency, okay? So treatments firstly always begins with validation of the narrative. That's the first thing that I tell people who come in, and people who come in especially for evaluation with their elevator speeches, you know, just relax, you know, chances are you're going to get a letter. Honestly, I've done probably 300 letters. I had to deny 3 times. That's it. And both of those 3 times, people had some really severe psychotic conditions that were not well managed or well controlled. They were not in treatment. That's it. So really, it's validation really important. Again, remember, we're looking for subjective sense of identities that only the person sitting telling you can tell you what it is. There's nothing that we can tell them otherwise. Be receptive, open, and most of all, investigative. Don't assume that the presence of gender dysphoria entails embarking on full transition. I'll talk a little bit about what full transition is and what's partial transition. And then it's our job as a clinicians to have people figure out where they fit on gender continuum. Why? Because a lot of non-binary individuals are struggling today. I think they're #1 underserved population today because we don't have social markers to kind of, you know, socially cue what their gender identity is. As a result, they're constantly misgendered as he or she. And that becomes a problem. I see a lot of gender non-binary people jumping into medical transition when that's not their goal, only so they can kind of stop being misgendered in society, and that's really sad. And that's our job to also inform them that it's a continuum. And even though society doesn't have markers to represent their gender, it doesn't also mean that they have to jump into something that is not really necessary. So broadly speaking, transition is usually for a lot of people, it's seen as some kind of physical body modifications through hormones or surgery. But transition is so much more than that. Transition falls into many categories, and this is just very briefly to say we have social transition. So that's when somebody comes out as their desired gender. That's when they have a chosen name or a pronoun that they'd like to use. Then we have legal transition when you change, you know, all of your documents, you change your driver license. We have hormonal transition, feminizing and feminizing, and we also have surgical transition, and that's when people undergo serious surgical procedures in order to further feminize or masculinize their bodies. Partial transition is really a variation of any aspects of transition and becomes really, really important not only with non-binary people, but also becomes really important with trans people, because I'm seeing much more people coming in wanting partial transition. So mastectomy, removal of the breasts, but they don't want phalloplasty. They don't want to have creation of new phallus. Very common today for various reasons, going from personal to that's not my sexual preference to, I mean, you just name it. So I think it's really important to keep in mind that partial transition is not only valid, but should be an option discussed with individuals when we're considering treatment for them. As I said, non-binary is #1 underserved population. I consider it invisible handicapped. They struggle with passability because, again, there's no social markers. They're currently #1 underserved population, and they tend to rush into transition. And again, I see that a lot where people come in and other things that non-binary people sometimes are not aware of because we're not educating them and medical doctors are not educating them, is that hormonal transition doesn't have to be a full-blown hormonal transition. Okay, so for somebody that is non-binary but just want to masculinize a little, microdosing, which taking low dose of testosterone is an option. Same for anybody who wants to feminize just a little bit, taking low dose of estrogen, maybe even without testosterone blocker is also an option. Okay, or partial, maybe surgical transition is also first option. I have somebody that just want to have a very, very androgynous type of look, that they're part of surgical transition. They're not interested in really looking very feminine or very masculine, and that's totally valid. Again, I'm not assessing for their preferences, for their choices. When I'm writing letters of evaluation, primarily I'm assessing for gender dysphoria, and then I'm assessing for capacity to be able to consent to medical treatment and for any kind of dual diagnosis. So let's get into dual diagnosis. As with many individuals, as you know, when one experiences severe distress, such as gender dysphoria, comorbidity is going to exist. That's just inevitable. That's just the way it is. And with gender diverse people especially, some of the factors that contribute to dual diagnosis. Well, when you're being stigmatized and harassed and discriminated socially, when you're being misgendered constantly, chances are depression is going to follow. With that, you're probably going to start to cope. And you're probably going to cope in like the most unhealthy ways: drinking, taking drugs, self-harming. Suicidality goes up. When there's lack of access to medical services, also the comorbidity is going to go up. And today we have a lot of issues with lack of medical services. I like to say that healthcare for gender diverse people is a privilege and not a right. What I mean by that is, even though insurances are starting to pick up services more and more, they drastically vary. Some insurances for a bigger company will cover everything. Some won't cover, barely will scratch the service. LA Care, for example, will cover everything, which is great, but how many doctors take LA Care? And how skilled are those doctors that take LA Care? So it's really not a right. It's kind of like a privilege depending on your social economic status, and I see that constantly across the board. Patients that have financial resources can surgically fully transition within a year and a half. Why? Because they have these resources. And patients who don't struggle. And that's because there's lack of accessibility. And so as they struggle, the dual diagnosis will also go up. So some of the common and less common dual diagnoses, as I said, depression, anxiety, incredibly common. When we're working with people who come in and they're very depressed and very anxious and have presence of gender dysphoria, studying hormones is paramount. If hormones is right for them, and if that's what they want to do, that will drastically decrease their depression and anxiety. So that's just kind of standard, at least for me. If that's something they want to do, if that's part of their transition, getting them started on hormones, especially if it's trans-identified, feminizing type of individual, setting them on low dose of estrogen can be very helpful. And they won't have any secondary kind of changes that can give them away. So people can still stay in a closet, but be on hormones. I have people who've been, on feminizing hormone therapy for like 6 months up to a year, and they haven't come out to anybody yet. And the only physical changes is very mild, slight growth of breast tissue, and they're able to kind of cover that up. But they're able to function better, and they're able to, live their lives in a little bit more kind of congruent and happier way. Substance abuse is another, again, second most common dual diagnosis. We have mood disorders, psychotic disorders, and this becomes incredibly important, dissociative identity disorder. For some reason, I'm seeing quite a bit of population that have dissociative identity disorder when they come evaluating for surgeries. I'm not sure why yet, but the problem with this is, or the problem with pretty much psychotic and dissociative identity, which is part of psychotic disorders, when we're diagnosing individuals, it's not so much the presence. Okay, so it's not so much the presence of diagnosis that's the problem, or should preclude people from getting medical services. The problem becomes who is consenting, which part of the personality is consenting to the surgery. And WPATH has written very little on this topic, and clinically this is a very big issue. So when I get somebody with dissociative identity disorder, I have to do a lot more footwork, not only to find out if they're stable, if what the level of their psychosis is, if they're seeing somebody, but also what are their alters, what are their personalities, have all of them consented to medical treatment? Because I've seen people with personalities ranging from, and it's very common that would be, non-human personalities within the body, right? And it also ranges in genders as well. So I've seen people where I want to transition to, trans feminine kind of end of a spectrum, but I have this, male part of personality that's very protective. How does that part of personality going to feel when you're going to really feminize? So this is an issue that nobody's really talking much about, or we're not doing enough research to really properly serve this population, but this is becoming much more common.
This is just, one thing I don't see up there is the higher prevalence within the population of people who are on the autism spectrum.
Yes, thank you so much. Yes, I noticed that today when I was practicing this morning that I didn't include it. That's excellent too. That's number 2 that I see most common pattern too. That's correct. People who are on autism spectrum tend to present much more with gender incongruency. And so there's a lot of research in that category apart from DID, but there's a lot more reading out there, but thank you. That's an excellent point. So when do we refer out? I can't stress it enough. Assess your level of competency, okay? Now, there's nothing wrong if you're really passionate and you want to work with gender diverse people. We all have to start somewhere. I certainly did when I started 10 years ago. My level of competency was non-existent. But make sure that you're in the very least transparent. So if somebody comes in and you want to work with them, let them know that you're studying out, you're passionate about working with gender diverse people, but you're still in a learning phase. Let that person make a choice, because you don't know who's coming in for what kind of issues. If somebody comes in because they need help coping with their comorbid diagnosis, because of the severity, chances are you probably won't be able to help. If they're coming in to be evaluated for a letter for any trans surgeries, you're probably going to streamline and prolong the process until you yourself, because you're going to be scared, and that's natural, right? I don't think there's a big liability risk, but a lot of people tend to be afraid of, some form of liability risk working with this population that, oh my God, what if I give them kind of green light permission to get surgery and they come back and they file a lawsuit because now they want to have children and their ovaries have been removed. Again, I'm not assessing what's the person going to do 5-10 years from now. I can't do that. We're assessing for the presence of gender dysphoria. We're assessing for presence of any dual diagnosis and if they're managed and well controlled, and capacity to give consent. And at this point of time, if somebody has enough distress and that's their next course of treatment that can help them, that's their choice. We also have to honor the autonomy of their body choice. So if you lack in competency but want to work with the population, nothing wrong. Again, seek workshop, lecture, seminars. I'm always open for anybody working with this population. Give me a call, email me. I'm an open book. I don't charge for consultation. I'll walk you through it. If you're having people walk in that need to be evaluated, you've never done it before, but you still want to evaluate them, let me know. I'll even give you my template that I use to evaluate people, and I'll show you, how to properly evaluate. So don't be afraid to reach out to people that do focus on this population, because people like myself who really work with this field, in this field, we do want to help and educate. That's the whole goal. This is why I'm here today. So I want more people to do that. Yes?
On that note, and I'm not affiliated with it at all, but coming up, I believe it's in August, there's a Gender Odyssey taking place down in San Diego, which is a great conference if you wanted to get more skills around that.
Thank you.
August 1st.
Yeah.
Thank you. So there's WPATH has great workshops. W has started to do a great lecture seminar. It's at I always confuse with Cedars-Sinai. It's the Mount Sinai in New York City. It's a surgical trans conference. They did it this year, second year in a row. It is excellent. You just have to sign up for the dyadic portion, and it's great. It has who and who in terms of surgical experts talking about any kind of advanced surgical enhancement skills, and it's a great starter. It's a great conference for you to go to and educate yourself. So you must seek consultation and or supervision, and if dual diagnosis is present and is out of your scope of competency, you must refer. I only focus working with gender diverse people. I don't work with substance issues. I don't work with, for example, any kind of sexual issues, even though I do talk a lot about sexuality because my background in sexuality as well with this community, but I don't really treat for any sexual issues. So there's a lot of things that I don't treat for. So if somebody has any kind of, presence of dual diagnosis that really need to be seen and treated by a specialist or by somebody that focuses on it, don't hesitate to refer them out. Otherwise, we're not doing justice to our clients. We're really not helping them. So that's pretty much. I think I'm just very close to my time. These are some of the references and sources for you. And if you have any questions, I'm definitely here for you. Now I can breathe. No questions? Everybody? Yeah.
So I've been seeing in discussion, because I don't work with this population, but or with transgenders, but I don't work with minors, and it's kind of like a hot topic of adolescence, junior high, where my friend said this, now I think this, and there isn't a long pattern of consistency. There's not a lot of history there, and the parents are saying, no, if that's true, I want to be supportive, but they're very squirrely about saying, like, well, maybe this is just a phase or something like that.
Mm-hmm.
I'm just curious what your thoughts are.
Okay. So here's my thoughts on working with minors. That's a specialty in of itself.
Yeah.
I don't touch minors. I work with adults. Why? Because I think you need to have a strong background in child developmental psychology to work with minors. You need to know all those developmental milestones, all those senses of identities and how they kind of tend to solidify together. So I personally stay away from minors just for that reason. Again, it's a specialty in of itself. I refer people to Children's Hospital. They have great trans programs there. And then I have a few other people, and that's what I do. Yeah, so sorry I couldn't,
No,
yeah, but again, it's even specialty within this specialty. And I think that's really ethical thing to brush this up to, because we can't all do everything. Yeah, yes.
Have you ever had a client come back and then realize that they made a mistake? Or
Yes and no. So yes, I had 2 people come back. They did not realize they made a mistake. What happened is that they experienced severe trauma. So I had somebody that transitioned as a trans woman, was very passable and living their life, and then they had a sexual abuse trauma taking place at work, and as a result, they couldn't really cope with it, and so they did transition to their male, male gender as part of like defensive function to protect themselves. So I've seen that, but I've seen it only in cases where it's severe trauma. Something has happened to people. I have yet to see somebody that walked in and has transitioned and feels like they have made a mistake. Because usually what we do, people come in and they have, let's say part of treatment is transition. We don't just send them for surgeries. That's what people need to understand. Nobody runs and gets surgical procedures. You start slow. You start on hormones, right? You start coming out. And every step of the way, what we're doing is, at least me, I assess, are you comfortable? Have we done enough? Is there something more we need to do? What part of surgery is right for you? So by the time somebody gets ready for surgery, chances are they've been on hormones for a while. They've been living, in their expressed or desired gender for a while. They're pretty certain. So again, yeah, that's I think one of the reasons why we're not seeing that. People are pretty
people
certain.
need letter just to get the hormones?
Not in California. So it's still in some states they do, but in the state of California you don't, because it's a consent state, meaning you just go and you basically consent to medical treatment, and a medical provider does the assessment. Thank you. Yeah.